Everyone thinks it's menopause when you have 1 year without a period, but really it starts years before. We, in our practice, see a lot of teens with acne, teens with irregular periods, painful periods, PCOS patients, so that as soon as you start your period, you could have a hormone imbalance. Too much estrogen is a risk factor for breast and uterine cancer. Think about your ovaries as a monthly paycheck. Your adrenal hormones, DHEA converts in the periphery to estradiol, estrone, testosterone, and that's the source of your hormones. I see a lot with autoimmune issues too, low DHEA. The autoimmune problem suppresses the DHEA and the cortisol or vice versa, but my patients feel better from an autoimmune standpoint when their DHEA is better, so we always check that.
Welcome to Autoimmune Alchemy, where we turn complex autoimmune science into clear, practical steps you can use to feel better and take control of your health. Welcome to another episode of Autoimmune Alchemy. I'm your host, Dr. Melissa Mandala. Today, we have a very special guest, Dr. Tara Scott. She is wonderfully a trailblazer in the hormone field, especially when it comes to integrated functional medicine. I love all the work that she's contributed. She has some new research that we just want to bring to you, not only suffering from autoimmune conditions, but those who may have hormone imbalance. So thank you so much, Tara, for being here. It's always a pleasure. And I'd love to just hear what got you into this field.
Yeah, so I'm a bit of a dinosaur in this field because I've been in the hormone space specifically for 23 years. So shortly after the WHI, there was not a lot of information for women and everybody was in a bit of a panic. I am a traditionally trained OBGYN, so they obviously are coming to their OBs for information. And for me personally, I had a special interest in hormones as I struggled with my own hormone issues from a young age, never was able to conceive without fertility drugs. So after you go through your own hormonal challenges, and thankfully through the modern medicine of fertility drugs, I was able to have kids. But then after that, you're still left with the same hormone problem. And there's really nothing for you until menopause. Now that's changing now, 20 years later, it's backing up so that younger women are getting different options with the rise of integrative and functional medicine practitioners like yourself. But that was a bit of a vacuum. And so I first became a menopause practitioner, certified menopause practitioner in 2006. Then I went on to do my fellowship in functional medicine through E4M and also got a third board certification in integrative medicine in 2015. So I'm just so glad that so many more providers are coming into the space, that we have so much more evidence and literature and publications to back up what we're doing. So it's an exciting time to be here.
It is an exciting time, and it's amazing that you've been able to help so many women and so many people through each generation and each decade. So if we can just back up a little bit, and what happens? When do these hormones start to, be abnormal? When do people even start looking? Because sometimes people think, well, maybe not till after, kids, or when is a good time to even consider hormone health?
That's a great question, and everyone thinks it's menopause when you have 1 year without a period, but really it starts years before. We, in our practice, see a lot of teens with acne, teens with irregular periods, painful periods, PCOS patients, so that as soon as you start your period, you could have a hormone imbalance. Now, it could be genetics, it could be our environment, it could be what you eat. As an expert in lifestyle medicine, some of that has to do with it, some of it doesn't. And so we are seeing younger and younger girls in their 20s and 30s with migraines, painful periods, not just infertility. Some of them are coming to us for that. The majority of who you hear about having hormone issues will be in that, when you're in your 40s and you start having irregular periods. But our patients that are younger are having these issues even before their periods become irregular. So to answer your question, really at any age it can happen. Most of the time, it isn't until perimenopause, but it can happen at any age as soon as you start your period.
Yeah, I often see this in the clinic, even teens with just painful periods, PMS, PMDD, just not able to regulate their mood, their discomfort, and it affects their quality of life. and the migraines. So when we think about this, what have you seen in terms of prevention, and people always wanting to know what they can do, and is it right or wrong to even request labs? Because, sometimes people are just discouraged or they just don't know when to pull the trigger. Love to hear your input.
Yeah, that's a difficult situation when you're navigating the traditional provider, because as an OBGYN, I can tell you we get no training in this. We do 3 months of reproductive endocrinology, which is and infertility, which is basically very heavy for infertility. IVF, how to use fertility medications, ectopic pregnancy, some endometriosis surgery, but it's really not geared towards the person with a hormone abnormality that doesn't want to conceive or isn't trying to conceive. So anybody who has any extra knowledge has to either have a personal interest from their own experience, from a family member, or has done kind of extra training. The traditional model is still not to check hormones, that it's difficult to check hormones. Now, we have protocols to check hormones if you're trying to get pregnant. Obviously, nobody argues that. We have protocols to check hormones if you want to diagnose PCOS. So they're the same labs done at similar times of the cycle that we're just interpreting to see if there is an issue with the hormones. We have lots of data saying, on day 3, your hormones should be this, on day 10, on day 21. So it just takes someone to connect the dots and saying, so if you're asking me, when is it too young to check hormones? Well, we'll see girls after puberty, but until they're really regular, it takes them from the first menstrual period to about 18 months to be regularly ovulating. We'll test them even before puberty, possibly depending on their complaint. Women who are breastfeeding or postpartum and not cycling, we may or may not be able to glean much from their hormone tests. But anytime in between, we are still able to check hormones unless you're on something that's suppressing your hormones, like an IUD, like an implant, or like an oral contraceptive. Even with that, there are other hormones such as testosterone, DHEA, insulin is a hormone, other things, thyroid, that we can check even if you're on a birth control pill, or we can be intentional about checking your pill-free week. So I think anyone who has any kind of cyclic complaint or anything that seems to be tied with a certain time of the cycle would benefit from getting hormones checked.
Yes, it's so amazing to just know what the options are and understand the pathophysiology behind it all and the timing of it. And I know a lot of women also wonder, can I even get my labs checked if I am on a birth control? Is that even accurate? Or if I do have an IUD, when do I get it? Do I wait after and that timing? So if you can just explain what that means and how it can or cannot be helpful.
Sure. So, I do see a lot of patients that need contraception. If you need to prevent pregnancy, you need to take birth control. And if you choose to take oral contraceptives, that is what it's designed for. If you're coming to me and maybe you're done with your family and you've had your tubes tied or your partner's had a vasectomy and they put you back on a birth control pill to control your periods or your symptoms, then we may ask them to stop the birth control pill to check the hormones during a natural cycle. But if you're one of the first category that you're like, oh no, I do not want to get pregnant, what we normally do, we'll check hormones during the pill-free week. Now, the definition of the birth control is to prevent pregnancy and prevent ovulation. So we already know you're not going to be producing the same amount of estrogen, estradiol, and you're not going to produce progesterone. That's the whole point of a birth control pill. So we know that's going to be low. But what we might check in that pill-free week is, how responsive is the brain, the pituitary, that FSH, to getting that next follicle ready as soon as you have a pill-free week. That's more for somebody in perimenopause that we don't know what their ovarian reserve is. But for somebody that's younger, and we can still look at androgens, we can look at testosterone, we can look at DHEA, DHEA-S, we can look at cortisol, we can look at thyroid, we can look at metabolic markers in that time period, in that pill-free week, and that's normally how we do it. If you have an IUD, you may or may not be ovulating, and you may or may not be bleeding, having a withdrawal bleed, so it's difficult to tell. So normally what we do with those patients is we'll check a set of labs. Now, our normal hormone panel would include FSH, LH, estradiol, estrone, free and total testosterone with an SHBG, DHEA, DHEA-S, progesterone, and maybe or maybe not a cortisol in the metabolic labs. So we'll do that full panel, and we'll do it, and then we'll repeat in 2 weeks, just the FSH, LH, estradiol, and progesterone. And the reason why I repeat it is because let's just say your body does cycle and you don't know because you don't bleed because of the IUD, then we get, the first set of labs, and by looking at the 4 of them and the relationship, we can determine, is that before ovulation, is that during ovulation, or is that after ovulation? And then 2 weeks later would potentially simulate a different part of the cycle. If you're someone who's anovulatory, you might not see a difference, but that still gives us the information. So you can absolutely get labs done if you have an Implanon in, if you have a Mirena IUD. If you're on the Depo-Provera, that's a little bit more suppressive. We will still check hormones, but we can expect everything to be kind of low, just like you would on a birth control pill. So there is a way of figuring certain things out. Now, sometimes it's like the devil that you know, right? So like if you're on a birth control pill because you need to provide contraception, like we don't like to take patients off if that's their choice, right? We might talk to them about, well, could you do another form of birth control? How about a diaphragm? How about a condom? Maybe an IUD, maybe a non-hormonal IUD. It's up to them and their partner on what they decide. If we feel the birth control pill with its suppressive nature is causing the problems. Now, in your realm, estrogen is anti-inflammatory. So for autoimmune issues, we see a bump up of autoimmune problems with women in perimenopause and menopause. So that estrogen helps people. So if they're having flares of their autoimmune issues, they may do better on a birth control without estrogen, a less suppressive birth control. And that Mirena may or may not suppress ovulation. Part of the mechanism of birth control is to make the uterus more hostile to sperm because of the progestin. So the sperm theoretically, it's not a barrier, but it's not as successful at getting into the fallopian tubes where conception takes place. You may or may not ovulate. So it's not always suppressing ovulation. Sometimes it does, sometimes it doesn't. And so the act of suppressing ovulation causes a lot of hormone symptoms for women. So if you think about it, think about your ovaries as a monthly paycheck. You get paid estrogen and progesterone every month. And then when you retire, you're going to live off of your savings account. Your hormone savings account, or your 401k, is your adrenal hormones, DHEA, because after menopause, that's the source of your hormones. DHEA converts in the periphery to estradiol, estrone, testosterone, and that's the source of your hormones. So I see a lot with autoimmune issues too, I don't know if you do too, low DHEA. Now, which came first? The autoimmune problem suppresses, the DHEA and the cortisol, or vice versa. But my patients feel better from an autoimmune standpoint when their DHEA is better. So we always check that. So sometimes if the birth control is causing the symptom, because it's made to create a hormone imbalance, then we will talk through other options of birth control with them.
Right. It's so important to have that as an option because, we know that estrogen can be anti-inflammatory. And I also see that low DHA in our autoimmune patients, or sometimes even high DHA early on. And then so it's a combination. And how does that work? Because a lot of people are wondering, sometimes it starts with brain fog and then migraines. And then later on it becomes fatigue and then joint pain and all these other things that develop. What have you seen in your practice, and how can people know if they, if that estrogen is, or, hormone replacement therapy can be well fit for them?
So the first thing we generally see after the age of 35 and certainly into 40s is progesterone drops. And the reason is because you're born with so many follicles. You release an egg, roughly every month. And then the good eggs always go out first. So we know from a standpoint of if you try to get pregnant after the age of 35, you will be called advanced maternal age. I've heard people use geriatric pregnancy. I don't like that term. Advanced maternal age. Why? Because the follicle and the egg isn't as good of a quality. We know fertility declines. the eggs aren't as good quality. Well, if we take away fertility, you're still left with declining quality of follicles. And those follicles seem to produce, first, less progesterone. The ovulation just, because the follicle that's producing progesterone is, it's actually releasing the egg, and it's the shell of the egg that becomes the corpus luteum in the ovary after to produce progesterone until the placenta can take over at week 13 if there is conception. So that's the first thing that drops. So many women first start experiencing, I know I did in my late 30s, insomnia, anxiety, because progesterone helps you sleep. It's an anti-anxiety in your body. Water retention, because progesterone is also a precursor to aldosterone, which is a diuretic. So those are usually the first symptoms that happen in your late 30s, early 40s. And that can happen with regular periods. Now, as the eggs age, as you don't ovulate all your eggs. They say that maybe at the time of perimenopause, you have 3,000 eggs left. And they say maybe I don't want to get this wrong. I thought I read it was 500 are maybe the most that have ovulation, but maybe there's more. Think about how many weeks, how many months a year, and multiply that by your reproductive lifespan. But you don't come close to using your eggs at all. So as you get into your 40s, the rate that the follicles, the eggs are kind of dying is faster than you're ovulating, right? So not only do they ovulate and you get rid of the eggs that way, it's just that they spoil for a worse way. If you're thinking about a carton of eggs, you might be eating your eggs, but also they're going to go bad, right? So as that happens and you age, the follicle that isn't as good quality also doesn't produce as much estradiol. You might see ovulation earlier because it's like a poor quality egg. That's as good as it can mount the response. So then estrogen changes. You might see shorter cycles with less progesterone, less estrogen, or you might see longer cycles where there's not even an egg responding. Might be 30, 40 days or 60 days. So the amount of estrogen now changes. And so those symptoms are then different. I've seen new onset panic disorders, palpitations, come in the 40s, also weight gain. We can see breast tenderness, still insomnia, low libido, low energy, depression. So those can all be symptoms that are starting in your 40s when you're still cycling. As you get older and you start skipping longer and you're having lower estrogen, you can start having symptoms of vaginal atrophy, painful intercourse, UTIs, joint aches, dry eyes, vaginal dryness, all those other symptoms, fatigue, those symptoms that go around with just low hormones of both of the estrogen and progesterone. So really, I started learning about it when I was 38. I had to start taking progesterone at that point, and I see a lot of patients at that age on into their 40s that are starting with these hormone issues, even though they're not menopausal for years.
Yeah, it's so amazing because now we have more, not just evidence, but more people are realizing that and asking their doctors these questions. I have this hair loss, I have bloating. It's not just, IBS. It's not just some form of stress, and it's not just in my head, but it's also a hormone imbalance, which is very powerful. And as we look back, when people are thinking about hormone replacement compared to OCPs, oral contraceptives, can you explain a little bit of that difference? Because I know there's a lot of methods and a lot of people are confused. They're like, well, maybe I just keep taking this, but maybe there's something better.
Yeah, you just touched on one of my pet peeves. I have patients who've had their tubes tied, or their partners have had a vasectomy. They go into their OBGYN and say, I'm having night sweats, and they get put on a birth control pill, right? Now, it's not necessarily the doctor's fault because we don't get trained on what to do, and the doctor's trying to help, but that's all they know. So again, what is a birth control pill indicated for? Prevention of pregnancy. Well, if you've already got another form of permanent sterilization, you don't really need the birth control pill, but that's all they can think of for a hormone replacement. So I always tell, my colleagues this: if you have a patient that's a diabetic and their blood sugar is low and it's 30, it's more dangerous to have a low blood sugar, right, than high blood sugar. If you're seeing 30, 20, what are you going to do? Are you going to give that patient Splenda? No, Splenda has 0 calories. You need to give that patient glucose, right? Because the brain needs glucose before they can have a seizure. So Splenda is an artificial sweetener. It sweetens your coffee. It has 0 calories, but it doesn't do the same thing as glucose does. That's like a progestin. A progestin is a synthetic version of progesterone. It's made to prevent pregnancy. That's what causes the suppressed ovulation is the progestin. But that particular compound, while it can be good to prevent pregnancy, has been shown in other studies to increase the risk of breast cancer, increase the risk of blood clots, worsen insulin resistance, and cause other side effects. Those risks of the increase in breast cancer aren't huge, but it is an increased risk. And to me, no increased risk is acceptable trade-off when you already have your tubes tied or a vasectomy. So, there is, I think one of the studies looked at a birth control pill compared to an IUD, so 2 forms of birth control. And over the IUD, there was a 14% increase with oral contraceptives. Or I might have said that backwards, but there was an increased risk. Now, I don't know that they've done the study compared to nothing, but I still believe that we do know that progestins increase the risk of breast cancer. So I think that, and I'm forgetting your original question. I'm kind of, but why give a birth control pill? So when we give a birth control pill, your provider may be thinking it is giving you hormones back because it is a synthetic estrogen and a synthetic progestin. And years ago, that's how we started, is giving synthetic hormones. But if you look at every other endocrinopathy, right? Diabetes, we give human insulin, right? Thyroid, we give bioidentical thyroid hormone, unless you use Armour, which isn't bioidentical, but it's still levothyroxine, right? It's still chemically the same. It's desiccated. What about when you have a parathyroid issue? We give parathyroid hormone, right, for bone health. We give we don't give men synthetic testosterone. We give them bioidentical testosterone. It's in an injection. It's in a topical. For our patients that are transgender, we give them bioidentical hormones, right? So why is there even an option for women to have non-bioidentical hormones, right? So it is not an option in my mind for hormone replacement. It's a great option for preventing pregnancy, but not for replacing hormones, because what you're doing then in that patient that possibly in perimenopause has low progesterone, maybe they have normal estrogen, maybe they have low estrogen, maybe they have high estrogen. But once you give them an oral contraceptive, you're now suppressing ovulation. So you're decreasing their progesterone even more. And then you're giving them a synthetic version of estradiol. So if they're one of those high estrogen people, now you've taken them from high estrogen, low progesterone to no progesterone, higher estrogen. So you have not fixed the problem. Now, have you helped the symptoms? Well, it does control your bleeding because it shuts down your ovulation and it puts you on a withdrawal bleed. And most people have a lighter, shorter period. So the bleeding could be improved. But most people have worse hot flashes, worse breast tenderness, and worse symptoms. It's not going to help your sleep because the synthetic progestin doesn't help you sleep. It doesn't help your mood.
Right. That is a huge, huge difference and mind blowing because it's the opposite effect of what a woman really, really needs. And it's so almost discriminating, just like, why can't we have access to this and this valuable, pure bioidentical way of getting that hormone that can regulate us and give us that, be able to work, to be with our family, to be present. And when we think about this, a lot of women are trying to figure out, maybe they're the stage, or do I have my tube side versus not, versus, what would you recommend for some ladies out there who are like, well, now there's all this menopause talk and I want to preserve my hormones. What do I do? What would you say? And I'm sure there's multiple discussions here and how you personalize that approach.
Well, first of all, my favorite form of birth control is vasectomy. I mean, it's an office procedure. It's a local anesthetic, and you're not entering the body cavity. The tubal ligation is general anesthetic. You're entering the body cavity, and it is, you have to be put to sleep for it. So anyway, so how do people know? So before, when I started doing this 23 years ago, I was in a large OBGYN group, and they were kind of weary. They were like, why are you doing this? Because I had a decent reputation. I had trained in that town. I'd been a good resident, why do you want to do this? Why do you want to get woo-woo, all this stuff? And I'm like, I'm using micronized progesterone, which is FDA approved, progesterone. I'm like, oh, I'm not doing anything that crazy. I mean, I suppose prior to it becoming generic, maybe our patients need to take a compounded version for cost purposes. But, what I would recommend offering is micronized progesterone. It costs patients, maybe $30 at the time. And it used to be that one, the copay was higher, but now I've seen most patients is $10, $15 for a micronized progesterone that comes in generic. So it's a very simple solution for a lot of perimenopausal symptoms. And could you give it without doing testing? Possibly. We have protocols that we give it after ovulation to support pregnancy and fertility for people with luteal phase defects. So could you just do that? Sure. I mean, is there anything that could come of a harm? Well, we only have 2 doses. It's not very well absorbed orally. The half-life is super quick, so usually it's not like it accumulates in patients. So there's very rarely an overdosing of those 2. The only thing that I've seen in a very small, I've prescribed this for thousands of people. The only thing is there's a very small handful of people that have the almost like a paradoxical effect of progesterone. Instead of having an improvement in their sleep and an improvement in their moods, they get severely depressed, which is not what's supposed to happen. And I think what happens there is they have a SNP at the GAD enzyme, the GAD enzyme, so they're shunting their GABA to glutamate. And instead of getting that allopregnanolone GABA benefit, they're going into getting an excitatory effect, and it's having the opposite effect on them. That's my own personal theory. I can't prove that. But it's a very rare, I can count probably on one hand the number of patients that have had that adverse effect, but it can be very severe. So I usually tell all women that, hey, if you're feeling really, really depressed or having a suicidal thought, that is not supposed to happen, right? But it's a very simple, very easy way to help 90% of women in perimenopause,
Right. And it's so accessible and doable and tolerable. And I love that option. And I know when it comes to people who are, you said luteal phase defect. And I know that's for most people, they don't know, even traditional doctors, they don't necessarily are trained or believe in that. So what would you if you can just educate us here, so those who may have heard this for the first time.
Sure. Sorry, that is a reproductive infertility tech diagnosis. So we know when we teach the menstrual cycle, we teach on a 28-day cycle. So day 1 would be the first day of full flow. So you have a little spotting that isn't day 1. I tell my patients when you have to use protection, whether it's a pad, a tampon, a cup, whatever you have to use, day 1, full flow, that's there. So the spotting before does not count as your period until the full flow. That's day 1. Most patients will ovulate between day 12 and 16 or 18. We say 14. We teach on a 28-day cycle. So from the time that you ovulate to the time that your next period comes, if your body is producing the proper amount of progesterone, it should be 14 days. So if you're day 14 and you ovulate, your period should come on day 28. When you have a shorter cycle, 25, 26, you can have a shorter cycle as you age if you ovulate earlier. So if you ovulate on day 10, you could have a 24-day cycle. But if you think you're ovulating, some women know, some women feel cramping, some women have that discharge, that spinobarcate, we call it. It's the egg white mucus, or maybe they're monitoring temperature or something. But from ovulation till next period should be 14 days. If your body doesn't make enough progesterone, that usually shortens that period. So you might ovulate on 14 and have a period on day 25, so 11 days. So that is called a luteal phase defect, and that's a signal of low progesterone. Now, before, what we used to do is we used to do an endometrial biopsy at that time, which, those can be uncomfortable and painful. And then the pathology would tell us, well, the way the lining looks, it looks like it should be before the period, and it looks off, right? That's another way to diagnose it. We never do that anymore now. So it's either historical or by mid-luteal, so a day 21 progesterone level. And the progesterone level should be above 10 for a good quality ovulation. But you can diagnose that based on just a menstrual history.
Right, that's so interesting. I didn't know that's how it was done before. And because I have some women who said before, I got even the vaginal suppositories for hormone replacement therapy or rectal suppositories for hormone replacement therapy. And now, what would you say is the integrative functional consensus in your world of how to do menopause replacement therapy, and does it change over time based on perimenopause, menopause, post-menopause, because these are all very different times and symptoms wise as well.
Well, it's funny because in the hormone world, there's a little bit of an overlap between traditional doctors who do believe in hormone replacement and prescribe it in a traditional way. Maybe without testing, maybe they're using bioidenticals, maybe they're not. And so they're still hormone specialists, right? And then there's those of us that are integrative and functional. Some integrative medicines might be more apt to do diet, lifestyle changes, work on stress to try to help progesterone. That may be effective for the younger patient that is in their 30s, maybe early 40s. But when you get to the aging ovary, it's hard to manipulate that with diet, exercise, supplements, right? It's a aging ovary, right? It's a hormone deficiency. So there may be some people in our circles that don't believe in hormone replacement therapy. Just like maybe some people don't believe you should get your knee replaced. I don't know. I mean, that's a artificial thing, right? Or some people may not believe in Botox. Maybe that's a better analogy. But when you talk about hormone replacement therapy from an integrative and functional, of course, we want you to work on all the things first: diet, lifestyle, movement, sleep, stress management. To just give you a hormone without addressing those things, I think is only going to get you so far, because if your problem is that you're so stressed out and you're not eating well, I can give you some hormones. It might make you feel a little bit better, but it's never going to make you feel great. That isn't a reason to not give a patient. I mean, we have to meet our patients where they are, right? But my patients who have the crazy job hours, the crazy stress, or crazy family stress, or whatever, they usually get an improvement, but it'll be only to a certain point unless they address the stress lifestyle component. So when we're talking about hormone replacement, we have so many FDA-approved bioidentical hormones. We have different types of patches, although there seems to be a national shortage now, but we have 4 or 5 different doses of patches. We have some generic estradiol gels that are very good. I like the daily gel in the packets because it's a more appropriate half-life, more appropriate doses. There's 4 doses of that gel, maybe 5, rather than the pumps. Those are a little bit higher doses, so I don't like those as much. So we have all these bioidentical, FDA-approved, some come in generic, so minimal copay for most people. Now, of course, if you have a high deductible policy, that changes things too. But, that's what is standard of care in our arena. Now, the issue comes if you need to replace an androgen. An androgen being a male-type hormone, testosterone or DHEA. So testosterone is indicated for postmenopausal women with low libido. We give it off-label if they're premenopausal with low libido, or they're premenopausal with a lot of low testosterone symptoms and really low testosterone levels, which I've seen. I saw a 30-something-year-old yesterday that has had low testosterone for a while, and infertility is her issue. So low muscle mass, low energy, hair loss, low mood, those are all symptoms of low testosterone. But there is no drug company that has made testosterone in a dose for women. So that means there's no FDA-approved option for women. There are male dose hormones that are 10 times the dose that some of my colleagues recommend using a fraction of. I feel like that's very inexact. It's like taking a huge tub of water and saying just a smidge. How exact is a smidge, And plus they're recommending these big tubes of Testim. Oh, these are great because then this will last you a year. I've seen, menopause influencers say that. I'm like, but what's the beyond use date of that drug? It's not good for 12 months. What's the shelf life? It's listed on there. It's usually not longer than 3 months. So you're telling your patients to get the male dose Testim, use a little dab every day, and you got your hormones for a year. And I'm like thinking, is there no expiration date on that cream? Of course there is. There should be. So that becomes challenging to give women testosterone. You can use some male doses, some male injections, and you can space them out, make it a lower dose, less frequently for women. You can try that. Other than that, we'd have to have it compounded or specially made for the patient, which is what we most often do. So we have those options for patients. And I think that's coming a long way. Like there are some traditional menopause providers that are more open to giving testosterone, but they're still giving it that way, like I said, like an inexact smidge or pea size or whatever, rather than a more calculated dose and monitoring it as well.
Right. I think this is very, very important because a lot of women just think, oh, I just need estrogen or I just need progesterone. They try to pick and choose what they need and then thinking, okay, well, how about my testosterone? And sometimes it'll be left alone for 5, 10 years until maybe post-menopause while they're suffering with well libido and depression. And then they're like skipped and they're unfortunately the relationships are suffering. They're not happy. And so, but going back to the quality of life and offering testosterone is so important because, I have a lot of plant-based eaters and I recommend, of course, nutrition and everything. And it's helped a lot of women, but most of the time it's not enough, like we just discussed, and for these other symptoms. So I think it's so important to have these options and know the power of it. When we're talking about certain options, with bioidentical and when figuring out, the cream versus the, injectables for testosterone, and, people are like, I don't even want to do the pellets. So do you tend to personalize it? Do you base it, of course, evidence-based and scientific-based? What are your thoughts about that? Because I know it's almost like a wild, wild west out there for
It is. So we have some data on testosterone. We have a few studies on pellets and safety of the pellets. Those are smaller numbers in the hundreds in those studies. I'm personally not a fan of pellets for women for a couple reasons. One is because, it's a super compressed hormone that is surgically inserted into the patient. And if they have a side effect, it's there, right? And there's nothing you can do. You can't make it work faster. You can't get it out of their body. If women have irreversible side effects like enlargement of their clitoris or deepening of their voice because they have too much testosterone, which is not common but can happen, you can't take the testosterone away. You can't stop it. So I'm not a fan of that. The other big thing with testosterone is a lot of people don't think about testosterone can turn into estrogen with one enzyme, aromatase. So if you give someone a lot of testosterone and that person has that enzyme upregulated or turned on so that it sends that pathway, someone may get too much estrogen. Too much estrogen is a risk factor for breast and uterine cancer. So then you can't, and the protocols that I've seen for testosterone pellets, for most people, not everybody, there are some of my colleagues that do it very well, but they don't test the estrone and the estradiol. They're just testing the total testosterone. They're not even testing the free and the total and the SHBG and the dihydrotestosterone to see, is it going to dihydrotestosterone or is it going to estradiol? So that's one of my concerns. Now, men don't have as much of that issue. So pellets may work well for men because they have higher levels. They don't have cycles. Yes, it could still aromatize for them, but you might see the man boobs and the gut if they have that symptom. They might have those symptoms, or even erectile dysfunction if they're getting too much estrogen from that testosterone pellet. So we have injections that are concentrated in male doses. So it's hard, like we have 100 milligrams per ml. So as a matter of reference, we know that the male testes makes 5 to 8 milligrams of testosterone a day, right? So let's just use 5 milligrams for easy math. That means 5 times 7, 35 milligrams a week, right? So if you have a 50 or a 100, 35 milligrams per week and someone needs it. Now, it's not 100% bioavailable, so they might get a 100 milligram injection or 50 milligram injection once a week or something like that, let's just say, which averages out to be, a little bit more than 7 a day. But think about that for women. Women make a third of a milligram a day. So let's round up to a half for easy math. That's 3.5 milligrams a week. So how do you take 50 milligrams even if you do 0.1 ml, which it's an oil based. So what that means is to get out 1 ml of an oil based with a thin needle is very difficult to do. 0.1 would equal 5 milligrams, right? It can be done if you can find the 50s, but you can't always find the 50s. It's commercially available as 100. So no, 50 isn't an option. So 0.1 would be 10 milligrams. So if you wanted to give someone 5 milligrams a week, you could try to give them 0.1 every 2 weeks. You're still going to get a peak and a trough, so like a high level and a low level. So some people are going to be symptomatic, some are not. So some of my patients do okay with that. But I really like the ovary doesn't give you a huge amount and then nothing. It's like a little bit a day, right? If you watered a plant with all the water for a week, it's only going to absorb so much and then the rest is going to run out, right? So I like hormones that are more physiologic. That's why I like the patch. That's why I like, dosing. So we can do testosterone as a daily gel that's compounded for you. The benefit of that is it's a rather smooth, steady thing. 2 downsides, 3 downsides. One is it can be transferred to kids and pets. So if you have grandkids, it's on your hands, it can be transferred. So you have to be very careful about that. After you put it on, wash your hands or maybe wear it at night, cover up with a pajama. 2, it can accumulate because it's not a quick in and out, right? It's a very slow decay in your tissues. So if you're doing it day after day, I don't know where you are, Dr. Mandala, but we're in Ohio.
California. Yes.
Okay. He just had snow on the ground for the last few months. Okay. Now, normally in Ohio, we get snow, it melts. We got snow, it melts. But this year, so we had so much snow, we haven't seen the grass since December, which is unusual where I live. So when you put on topical and it doesn't get out fast, it can accumulate, right? For some people. So that's the other downside is sometimes you need a drug holiday, just like you would need a rest day for exercise. The third thing is we are mostly monitoring via blood, or most of the world is using blood. Some people are using urine and saliva. I use blood, saliva, blood spot, and urine. But if you're looking for testosterone to increase your serum levels, it doesn't do it as much as if you took any medication orally. When you take a medication orally, 90% of that gets into your system, right? Goes through your gut into the portal system. And when you draw your veins, you see the levels go up. So you'll see progesterone levels go up. Now it's a quick increase. So when you're taking progesterone at night, 8 a.m. in the morning, some patients don't have any left. Some people do have very high levels. You'll see all kinds of things for the commercially available progesterone because it's immediate release. For testosterone topical or any topical hormone, estradiol, the pharmacokinetics are you put it on your skin, right? It gets through your skin, it gets into the sub-Q, then you have all those little capillaries. It gets into the blood system. It's on the red blood cell for about 3 seconds, right? And then it gets taken to wherever it's going to go to. Let's just say it's going to go to your finger. So the testosterone goes to your finger, but then it doesn't get back into the vein. So when you draw the blood, you can see the level. It's going to be drained by your lymph system. So it's going to work on your finger. It's going to have the action in the finger cell, and then it's going to be drained by the lymphatics. So when we draw blood in the vein, we don't see a huge uptick unless you're using a high level. That goes for men too, and those studies are all based on gel and serum monitoring, right? They came from because they did the levels initially with a cream and they didn't see the levels go up. So an alcohol-based gel penetrates through your skin better, and you'll see more of a spike with any hormone in a gel. Now think about hormones. If you think about the steroidogenic cascade, they're on the right side. So it means they're fat-loving. They love to be lipophilic. So they love to be attached to proteins in the blood. They love to be in the sub-Q and the fat, and they hang around there. So the downside to taking testosterone as a topical is if you only want to monitor via blood, you could be underestimating the amount of testosterone that person is getting. But still a very effective way to give it. It doesn't stop me from using it that way. We have just started giving it as a troche. So there's no oral testosterone for women, There are a couple options for men that are new to the market. And some of the studies are showing that the old salts that we had, it was methyl testosterone and testosterone, something else, I'm blanking on it. When we gave those to men or women, it caused liver toxicity. So we shunned away from giving testosterone orally because we didn't want it to go in the liver. We didn't want it to cause liver function tests to go up. Also, when you give anything oral for estrogen and testosterone, and it makes the liver start working, so it increases blood clotting proteins, it increases binding proteins, and it kind of messes things up. But there's some newer testosterone and decanoate for men, Kysotrex, that seems to not have a liver toxicity. So we're hoping we might see that come to use for women, but for now we are advised not to use oral testosterone for women. So we can use a sublingual version where you either, it appears like a little square and a triturate is like a tiny, tiny little it's not really like a Tic Tac because it's not as hard as a Tic Tac, but like a little, I don't know, like a pop rocket or I can't think
Yeah,
of
it's something that dissolves a little bit.
It's dissolvable. So it dissolves. Yeah, it dissolves underneath your tongue and goes directly into that blood system and gets into your system. So I actually really like that form for women because then we can trace it. We see it. You have to time it. You have to understand what we're talking about is half-life, which means how high does it get and when do we give it and when do we test it. So all those things I have seen. I had the benefit of being trained by a compounding pharmacist when I started this journey 23 years ago. So I'm always thinking about half-lives and absorption. And when I'm thinking about timing of labs versus dosing, the tradition, even the most integrative providers don't think about that. So I'm very fortunate because they'll think about okay, just give it, then test it. Well, you got to think about it. When we give antibiotics, we do peak and trough levels, right? Remember that from residency? So you have to think about that when you're testing hormones, when you're giving a drug, when you're not just measuring endogenous hormones or the hormones that patients make on their own. That's different than the hormones they take.
Right. I love my compound pharmacist too, right? It's amazing because we can learn so much from them and knowing the timing. And I think it's so important to always track labs and the timing and know what you're dosing and the half-life. All of that's so valuable and more evidence-based and more accurate. And I think, and then it just reassures the process as well. So when we're thinking about, I love getting AM cortisol urine and just kind of tracking that as well. And can you explain the difference to people out here who may not know DHEA versus DHEA-S? And because sometimes, once again, there's so many different ways of checking labs, but sometimes they only get 3 labs from certain doctors. They're like, hey, where's everything else? So can you explain the difference?
Wow, I used to just check the DHEA-S. So DHEA is the hormone made in your adrenal gland, 90% of it. And the sulfated form comes after the liver. So you have sulfonyluretransferases, sulfatases, and those are just part of, I don't even know really what the purpose is to make it DHEA. That's a great question, but we traditionally would measure DHEA-S, which is a sulfate version. And as an example, let's just say the normal lab is 27 to 237. It's supposed to be an age-related range, should be the highest in your teens, and it should be different for men and women because men have more of it. And then as you age, there should be different. Some of the labs will break down 31 to 40, 40 to 50, but some of the labs just give you a generic 27 to 237, around there. What I started seeing, though, is some people had high DHEA-S. Now, that could be stress. That could send that level high. But I noticed even in myself, it would be high. I'm not taking it. And it would persistently be high if I would take it, if I would not take it. And so some people have a sulfatase SNP, meaning, an enzyme alteration that pushes things down that pathway. And so no matter what they do, that is where it's going to be. Like aromatase SNP, it's going to be higher. So when I check the DHEA unconjugated, my lab will give me a follicular, mid-cycle, and a luteal, and then maybe a post-menopausal range. The luteal lab is 414 to 1187. I'm paraphrasing. It might not be exactly that. Somewhere around 4-ish to 11-ish. meaning that the normal range would be somewhere in the 800s. So a wider range, a more populous, more volume of that hormone. And then the postmenopausal range is 77 to, I think, 781, around there. So if patients were sulfating it, you'd get a falsely elevated level, then you'd think they're fine, especially if you're supplementing it. The other thing is the half-life is 36 hours. So anytime they take it the day before, it could still be elevating it. So what we really want to know when we're checking estrogen is what is the peak level with the hormone. But when we're supplementing DHEA, we kind of want to know what's the trough level endogenous without the hormone, right? Because we want to see, is your body doing okay? Do you need it? I mean, you could do peak levels, I suppose. So I have patients not take it for 48 hours, or if they're not taking it, they just go. And I look at the DHEA unconjugated plus the DHEA-S. And so now I've seen some people with a very low DHEA unconjugated and a high or a normal DHEA-S because they're pushing it down that pathway. It'd be like if you had a ton of money in your 401k and nothing in your savings account. You can't use it to pay your mortgage because you can't touch your 401k till retirement. So what good does that do if it's all pushed down one place? You need to have, you need to have it. So it does matter. And I started checking both. That DHEA unconjugated level, though, I believe is like a frozen. There's some way in the lab has to handle it differently. So I don't know if you've experienced it. Sometimes they don't do it. They draw the blood and they don't look to see that they have to handle that specimen differently. So then you'll get they didn't run it, or they canceled it because they're like, oops, I didn't do this frozen. So they just cancel the order rather than sometimes they tell the patient to come back and redraw it. But so that's why I like to check both of those.
So important. And I think, a lot of women too maybe they've had history of breast cancer, maybe even in their 30s and then their 40s and now they're 50 or 60s, or maybe just finished treatment and they're on an estradiol or some aromatase inhibitor, and then they just didn't like the hot flashes and all the symptoms that came to it. And I have a patient that switched to alert. I think the larotasisol or one of those. And so what do you advise, when is it ever safe? Is it maybe 5-10 years after, or is it personalized, or is it a low dose, or are we just treating symptomatically with, traditional medicine, gabapentin and SSRIs and trying to get that optimized? How would you handle those situations? As of course, people are very curious now because of the bioidentical hormone options as being more, I would say, publicized. And what would you do for those types of patients?
That's a huge, huge question. And the answer is going to depend on an individual. I always like to know patients' stage and grade, right? And obviously time of diagnosis, premenopausal versus postmenopausal. An extensive history. Do they have any of those genetic mutations that increase their risk? So if you have a breast cancer patient, and you look at, we kind of use the Menopause Society as our standard. So if you look at the menopause position statement from 2022, which is the last one that they've made, it does not say, don't ever give any breast cancer patients any hormones. That's not what it says. What it says is, for breast cancer survival, well, first of all, let's back up. A woman's risk of breast cancer, just sitting here, my risk, 13%. If you choose to take bioidentical hormones and you don't have breast cancer, your risk is 1 out of 1,000, so 0.1%. So my risk, because I take bioidentical hormones, is 13.1% compared to my risk without it at 13%. Now, if you take something like Prempro, which is synthetic hormones, your risk is 3 out of 1,000. So the Menopause Society defines that as a negligible increased risk of hormone replacement for breast cancer. The FDA warning of breast cancer risk has come off the packages, or should be coming off soon. In November, they voted to take it off. So for the breast cancer patient, that's a little bit different, right? So did they have breast cancer premenopausal, postmenopausal, and when did they get it? So the first thing you said, is it 5 years, is it 10 years? Well, first I want to know what kind of cancer they had. If they had a triple negative cancer, all the receptors were negative, there's technically no contraindication to take hormone therapy because it's not thought to be hormonally fed. If they had a breast cancer and they're still on treatment, I don't like to intervene and muddy the waters. I like them to finish their treatment. That's between them and their oncologist. And then we can work on other hormones, cortisol, diet, everything else, right? So the menopause position statement says, for a patient with breast cancer, hormone therapy is generally avoided. It doesn't say absolutely never give. It doesn't say, contraindicated. It doesn't even say contraindicated. Generally not advised. However, for severe vasomotor symptoms unresponsive to other treatments may be considered with shared decision making with the oncologist. It doesn't say 5 years, 10 years. It doesn't say 2 years. It says the patient can decide. There's several studies that have been done, some of them in Europe, giving hormone therapy to patients that are breast cancer survivors. And in those smaller numbers, I don't even know that number offhand, how many, I'm going to take a guess, it was maybe a couple thousand, that they didn't see an increased risk and recurrence in patients who choose to take hormone therapy. There were some patients who were on an aromatase inhibitor and took some vaginal estrogen. In that study, different study, had a slight increased risk of recurrence, so they were worried about that. Vaginal hormones are thought to be safe no matter where you are in your breast cancer journey. My preference would be vaginal DHEA, which is FDA approved in the form of intrarosa versus estradiol, just because there seems to be less risk of breast cancer with DHEA because it doesn't convert, does not aromatize in the breast. It forms an androgen, which is not anti-proliferative in the breast. So it doesn't stimulate growth in the breast. It's the opposite. So when can you start hormone therapy in a patient? So that really depends. Like, yes, we prefer to have them 5 years out. But I've had patients that are miserable and they've tried other hormones. We do have, I'm not going to pronounce the generic name, Veoza, and I think there might be another one that was approved for hot flashes in women. That is a non-hormonal therapy. It's a bradykinin receptor. In some studies, there was also an improvement in sleep, but it doesn't help all the other menopause symptoms of low libido, of low energy, of joint aches, of all these other things. So vaginal estrogen, yes. Those supplements, yes. I'm not a huge fan of gabapentin. I think it is one of the options, absolutely, for patients. I just think there's a lot of other side effects to it. So if the patient is desperately miserable, interpreting the menopause position statement, you could give them hormone therapy. And I tell the patient, listen, I have no study to prove that this will not increase your recurrence. We have some small studies done on some breast cancer patients that there hasn't been a recurrence. There was another study that was published early last year that was 7 million women who were Medicare age. 7 million is a lot of people, right? And this data cohort was in the early 2000s, like I want to say 2001 to 2008. So think about that. The WHI was 2001. So this was a time where if they were taking hormones, so it was probably Prempro. It was probably not micronized progesterone and estradiol. Maybe, maybe not. So these women were over 65, and the women that took hormone therapy over 65 had a 29 or 26% reduction in mortality and a 19% reduction in breast cancer, less lung cancer, less colon cancer, less stroke in the women that took transdermal hormone therapy. So this is women older, less stroke and less dementia. Now, people that took oral did have an increased risk, but not transdermal. So we have that data that's not in breast cancer patients. So that's in patients that there was no increased risk, even with those hormones used at that age. There was no increased risk and there was less breast cancer. So I just think there's too much with a breast cancer patient. And I do have some patients, I like to get them a year. I like to get them through their therapy. I don't like to go against what's been advised because a cancer patient is scared. They don't want to have a recurrence. Their oncologists also don't want them to have a recurrence. And they're only following protocols that have been proven to work for a population. It's not an N of one. It's not one person. So they're only doing what they're taught. They're not trying to, but they're thinking, I don't want this person to die. I want this person to live. You know, the survival rate is very high for stage 1 breast cancer. It's in I don't even know what it is, 95, 98% stage 1. So those patients they're probably going to live and they need to have quality of life, especially if they've been diagnosed. Now, the other special nuanced thing is, what if these patients have had a bilateral mastectomy? They don't have any breasts. So they don't have breast tissue. So how are we increasing the risk? Are they going by one little cell is going to be somewhere in the body, and if we give them hormones, might down the road get a met on their spine or something? They don't have any breasts. So all the things that go into our decision. Like, did they have a mastectomy? Did they have a bilateral mastectomy? Do they have any breast tissue? What was their stage? What was their grade? What was the size of their tumor? How long ago was it? Were they on hormones? Were they not on hormones? Were they premenopausal? Were they postmenopausal? I had a patient that came in last week that said, oh, I don't want to take hormones because my mom got breast cancer. And I said, well, how old was your mom? And she said she was 82. I said, was she taking hormones? She goes, no, she never took hormones. I said, so she was 82 when she got diagnosed. And you think hormones caused her cancer at 82? She went 30 years with no hormones. So how are you saying that? She goes, oh, it's hormone driven and she's on an anti-hormone. And I'm like, right. She goes, why are they doing that then? I said, I don't know. That's the protocol. That's been what's studied. She goes, well, why would they give her that then? That's just the protocol, right? So you're telling me a 82-year-old who has never taken a hormone in 30 years, and think about how low the estradiol is at that point, generally, right?
Zero.
And that caused her cancer? No, it didn't. So that's why we're saying, and even if you look at Averill Bluming's work, Estrogen Matters, I haven't read the whole book yet, but he gives study after study. I think he's a proponent of Prempro, so I disagree with that. But he gives all these studies that show estrogen doesn't cause cancer. It's not the estrogen you take, it's the estrogen you make, which is a whole nother topic, right?
Thank you so, so much, because this is all important to know the nuances, to know that there are options, and not to make assumptions, but to follow the evidence and the blood work and all these things. And I think women out here, they have family members that can just listen to this podcast. And I know you were just on, was it the menopause documentary, a panel or something? I saw you there.
We're supposed to have that event. It looks like it's getting postponed. But yeah, I can't wait to watch the documentary because that's another great vehicle to get information out there.
Awesome. So where can people find you on social media and your clinic? And how would you want to just share how they can stay connected with you and your work?
Yeah, well, I would love for them to subscribe to my YouTube channel. Lots of free information there. It's either under Hormone Guru or Dr. Tara Scott. You can find us both ways. My website, Dr. Tara Scott, also has a lot of free information. We've got a free download on testing. What do I do? How do I tell my doctor what I want? We've got a free advocacy checklist for your doctor, a free guide to natural therapies for mood disorders, and a free mini hormone course, all there on the website. We've got a free newsletter that comes out every week with information. Would love for them to sign up for that. And follow me on Instagram at Hormone Guru MD, and on Facebook and TikTok as Hormone Guru. Yeah. So we try to spend a lot of time putting a lot of free things out there because, my mission is to advocate, educate, and validate women.
I love that. Thank you so much, Dr. Tara Scott. It's always a joy and an honor to see trailblazers like you make a difference and an impact every single day in all avenues. We truly value you, your time, your community. So thank you for being here.
Yeah, and thank you to you and Micah. I know it's a lot of work to do a podcast, and so you guys are also dedicated to trying to get the information out. So thank you for all you guys do.
Thank you so much. I can't wait to see you again in the future, hopefully. If we have some more topics, I know we will, and we'll see you soon. Thanks for listening to Autoimmune Alchemy. If you enjoyed this episode, please follow the show and leave a review. It helps more people find it. You can find resources and links in the show notes.